to everybody who's been before. Thank you so much for being with these conversations and staying with them. And welcome to those of you who are joining for the first time to this gathering. Today, we are looking at freedom of religion or belief, which we always look at, but today it's about access to health as well, and our health and well-being, which is captured in the Sustainable Development Goal number 3. And the context for these conversations, as always in the series, is how can we ensure that we meet the overall SDG pledge to leave no one behind? That's what we are trying to work towards. And like I said, before we properly begin, just write hello. I can see everybody's already doing that. That's really, really wonderful to see where everybody's from. And yeah, so just to start about this topic, there isn't an international day this time that we are linking this consultation to. And in many ways, we don't need to, because we all remain in the midst of a global pandemic at the moment. And we are at a stage now where the global inequities, vaccines and access to health are evident if you look, and are becoming perhaps more evident. So only about 60% of the global population have received at least one dose of the COVID vaccine, but in low-income countries, it's only 9.2%. And in December, it's only across Africa, it's only about 6.8% of people have been vaccinated. So for those already struggling to access healthcare around the world, and this may be due to direct or indirect discrimination, and Mary will talk more about that. For those already struggling to access this healthcare, maybe because of their intersecting ethno-religious identities, where they live in the country, and all of these different factors, their gender, the religion that they're in, COVID doesn't bring any more security. And in fact, it is showing us where there are still gaps and patterns to work on. The 1966 Convention on Economic, Social and Cultural Rights, which is the other convention to where freedom of religion or belief sits, but it's the one that's received far less international attention. We're much more focused on civil and political rights. This convention on economic, social, cultural rights has recognized that the highest attainable standard of physical and mental health is really fundamental for all humans. But the intersection of this right with religion and religious identities are certainly still not very often looked at. And that's really what we want to have a look at today. There's a lot to explore. Religious institutions have been blockers to accessing healthcare in many different ways, especially for women's sexual and reproductive health rights. But our religions or beliefs themselves, which each of us experience personally, can also really inspire openings and opportunities to provide healthcare for all those in our communities, of our own faith or not. So we need only to think of the number of religious buildings that have been used to vaccinate the local communities during COVID, and you can start to see all of these dichotomies in play. So like I said, there's a lot to dive into. I'm really grateful that our speakers will be looking at that. Before then, just wanted to ask you, what are you hoping to learn and take away today? Just to have that question in your mind. And it helps to remember for today's consultation that we're all experts of our own experiences and contexts. We all bring unique insights. We are here to learn from each other in areas where our experience or knowledge does not extend. And this is a space for all of us, and particularly for those in leadership or decision-making roles, to be better empowered to help move from theory and conversation into practice now and through regional follow-up that we plan to do. So these conversations will, for example, feed into the International Panel of Parliamentarians on FoRB and others international gatherings this year and next year, and we hope also the UN high-level dialogue on SDGs in the summer. Parliamentarians and religious leaders are really important for bringing about new cultures and opportunities to collectively solve the problems that we face. They're in positions of influence for influencing cultural and moral narratives and behavior, and really importantly, are able to bring forward stories and experiences from those whose voices have been overlooked. So please note as well our advocacy statement. It was launched back in September during the Global Act for SDGs Week. That should magically appear in the chat now if it hasn't already. And it's an important personal recognition where you can sign in your own capacity to not overlook FoRB in SDG related work, and to seek and to listen to religious and belief communities' experiences and needs to make sure that we really do leave no one behind. So before we all move to conversations in breakout rooms, we are joined by some of those thinking through and working on FoRB health and wellbeing issues that SDG 3 raises. Do listen to what they share, see what resonates for you, and whether, and do share that in the breakout rooms. Please put any comments or questions in the chat. Everything you put really helps us learn. Thank you so much. So really delighted to hand over to Marie Yule Pedersen, who is our resident expert on all things FoRB and everything it connects to. And Marie's will help us, as a senior researcher at the Danish Institute for Human Rights, will help us look into these intersections and what they mean. Marie, over to you.
Thanks a lot, Catherine. I don't know if I'm an expert, but at least I have done a little bit of thinking on these issues and tried to put down some of the thoughts in the various briefs that have been published in cooperation with you. So in this very, very short presentation, I'll try to summarize some of the things that we wrote in the brief on FoRB and health. So the right to freedom of religion or belief is linked in very important ways to the achievement of Agenda 2030, as Catherine has said, and to the Sustainable Development Goals. And that includes SDG 3, which is dedicated to ensuring healthy lives and promoting well-being for all at all ages. In different ways, challenges related to freedom of religion or belief present obstacles to achieving this SDG and its targets. And if we want to ensure healthy lives and well-being for all, these challenges must be properly identified and addressed. And I want to give you two examples of two very different types of FoRB-related challenges to SDG 3. So first, as Catherine has also mentioned, discrimination of religious and belief minorities. So around the world, religious or belief minorities often suffer from serious discrimination. And this is rarely just about restrictions on their religious beliefs and practices. Most often, discrimination also entails inequalities in terms of access to public goods, and that includes access to health. And that obviously constitutes a major obstacle to SDG target 3.8, which aims to provide universal health coverage and access to essential healthcare services for all. So in the most extreme cases, we see health facilities being destroyed and staff attacked or even killed as part of violent oppression of minorities. In other contexts, access is restricted through discriminatory state policies and practices. Bias in health budgeting and priorities, for instance, may mean that infrastructure is lacking or of low quality in areas where there's a predominance of religious or belief minorities. Displaced minority groups living in refugee camps are obviously particularly vulnerable, with health services that are severely lacking and refugees having to rely on very basic primary health care. Religious and belief minorities also experience institutionalized discrimination, prejudice, and bias in treatment. And that can include verbal and physical abuse, refusal of treatment, or insufficient or wrong treatment even. And in contexts where there's a requirement to display one's religious identity upon entering the health system, the risk of discrimination may be even greater. And as Catherine also said, all these things have only been worsened with the COVID-19 pandemic. This pandemic has exposed and accentuated existing inequalities and discrimination. Poor living conditions and precarious job situations for many minorities mean that they have fewer possibilities for prevention, less access to hospital and to treatment. And in some cases, people from certain minorities have been denied access to hospital. In other cases, hospitals have practiced segregated treatment of minorities. And on top of all this, there are various examples of religious or belief minorities having been scapegoated in the pandemic, accused of intentionally spreading the virus. So if we want to ensure access to healthcare services for all, we must address these different types of health-related discrimination, marginalization, and exclusion that religious and belief minorities face. That was one challenge. The other challenge I want to mention is quite different. This is the challenge that concerns the use of FoRB, or freedom of religion or belief, as an argument to restrict access to certain types of health services, namely sexual and reproductive health services. So access to sexual and reproductive health care services for all is an essential part of women's rights, and it's a key SDG target 3.7. But as we all know, laws and policies and social practices around the world often restrict access to this aspect of health. Examples include restrictions on access to contraception and family planning, obligatory consent from a legal guardian, or restrictions on the provision of sexual and reproductive education and information. And even if many religious actors play crucial roles in providing health services more generally, we often see that religion plays an important role in sustaining and justifying restrictions in this area of health. But according to international human rights standards, the right to freedom of religion or belief does not protect religious practices that violate the rights of others. And that includes rights related to sexual and reproductive health. So religious norms and traditions are not a legitimate reason for restricting women's right to sexual and reproductive health services. Freedom of religion or belief cannot, for instance, be invoked to deny women access to contraceptives or to condition their access to contraceptives on their husband's consent. This is not a legitimate use of freedom of religion or belief. So obviously there are many gray areas and dilemmas that are not easily resolved in this. The issue of abortion, as we all know, is particularly contentious. And we see some people using FoRB as an argument for restrictive abortion laws and for conscientious objection, guaranteeing medical staff the right to refuse participation in abortion-related services. And it's important to say that the human rights framework does accommodate contentious objection, but there are limits. For example, conscience cannot justify a refusal to perform a life-saving abortion when no other suitable alternatives exist for a woman. And also in contexts where abortion is legal, but the majority of medical staff refuse to carry out abortions, conscientious objection effectively hinders women from enjoying their legally guaranteed access to such health services. So if we want to ensure access to sexual and reproductive health services for all, as outlined in target 3.7, we must pay close attention to the use or misuse of freedom of religion or belief as an argument for broad restrictions on these rights. And we must find ways to support a more inclusive understanding of freedom of religion or belief. So these were a few of the most pertinent challenges related to FoRB within the area of health. Now, what can we do to address them and contribute to ensuring healthy lives and well-being for all? In our brief, we have identified some basic ideas for action, and they are very basic, but let me mention a few of them. So when we talk about parliamentarians, there's a lot you can do. Parliamentarians can engage in dialogue with religious and belief minorities to ensure that their perspectives, experiences, and concerns are included in health-related laws and policies. You can also work to abolish institutionalized discrimination in health budgeting, for instance, through analysis of the budget to identify potential bias or under-prioritization of religious and belief minorities. And you can work to abolish laws that restrict women's access to sexual and reproductive health services, including, for instance, requirement of guardian or third-party consent, restrictions on access to family planning, and overly restrictive abortion laws. Religious and belief leaders also have very important roles to play in this. You can engage in the promotion of sexual and reproductive health rights and contribute to dismantling religiously related opposition. For instance, by promoting religious interpretations that support these rights and contributing to the development of context-sensitive approaches to sexual and reproductive health. You can encourage faith-based health providers to take a non-discriminatory and inclusive approach in their provision of health services, actively reaching out to religious and belief minorities. And you can communicate the health needs and experiences of marginalized minorities and communities to authorities and the broader public. These are obviously only a few very basic ideas, and there are many, many other ways of tackling these challenges. And I'm sure that many of you who are here today have plenty of ideas and experiences in this area. And I think that is precisely the main purpose of the dialogue today, to hear about your perspectives and experiences, and to provide a space for you to exchange ideas and experiences. So I will end here, and I look very much forward to the discussions. Thank you very much.
Thank you so much, Marie. You've brought up so many issues there, and you've gone right to the heart of where I know for some people there will be, for many people around the world, there's still a lot of fear, there's still a lot of uncertainty and unease about the tension that exists between some of the topics that you've talked about, and that is what we're not trying to avoid today. We're trying to provide a space, you might call it a safe or a brave space, to have this kind of conversation and not to ignore it, because these issues do exist. But if you are feeling uneasy, just to notice that and to bring that into the room, and we want to hear that. But what Marie's raised is incredibly important, and Bicbic will, who's speaking in a little bit, will be able to share more on these topics as well. And we know that the gender and the FoRB communities, people working on it, have been really separate, and we really want to bridge those gaps. But so many issues Marie has shared. Thank you so much, Marie. Really, really helpful introduction. And really delighted now to hand over to Jacek, Tyszko, who is the Senior Advisor for Faith Engagement at UNAIDS, and we'll be able to share a bit more about different international trends, dimensions, and just bring all the wisdom that he's had from working on these issues. So Jacek, over to you.
Thank you very much, Catherine. And I should say that your introduction, and especially the intervention from Marie, is making my input much easier, because many of the aspects you already addressed. But let me start from the kind of UN perspective on the intersection between religious identity and access to health. And as you've correctly mentioned, we have SDGs, we have specific targets, we have specific documents, we have finally something like probably most important constitutional character document, which is the Universal Declaration of Human Rights, which definitely clearly mentions freedom of religion as the entry point. But these are documents, this is something that is written, yes. The practical life tells us very clearly that absolute majority of communities in the world identify themselves as associated with faith or with a religion. We don't know if it is 90%. My personal feeling is that it is much more than that. And this is why UN considers faith partners as key partners, yes, as those who should be part of any discussion, global, regional, country, local level, that relates to SDGs implementation and that relates to the better future for all of us as humanity. Especially that we know that vulnerable groups exist in each of these communities, yes, and Marie was very well mentioning some of them, like minorities, including religious minorities, like people on the move, like many other groups, subgroups, individuals who are those that normally we are thinking about them when talking about those left behind, those who have no access, those who are somewhere at the end of the line, or very often even kicked out of the line. And here, taking into to account today's reality, we definitely see that the role of religious leaders and faith-based or faith-inspired organizations are growing seriously in emergency situations. So is it a conflict? Is it a disaster or environment related? Or as today's topic, is it a health emergency like COVID, like Ebola, like HIV/AIDS, which is my field of responsibility? So it is obvious that the role of our faith partners, religious leaders especially, are growing in such circumstances simply because the trust towards public institutions that are not able to deliver in such circumstances immediately is severely going down. So human behavior forces us to find support and like help in our faith leaders, in our religious leaders. And from here, let me go to barriers. Yes, we do have in this intersection many barriers, wonderfully summarized, some of them by Marie, which have two characters. One is a political and the other is practical, yes, like implementation kind of barriers, which are extremely important if we want to address it properly. Political, of course, they are, this is case by case. They are related to relationships between government, central government, and like the different churches in a country, between local government and the dominating church in the area, between the community leadership and the faith leadership within the same community. There is also this political challenge related to representativeness, yes, where very often in many cases, many countries, religious leaders representing their communities, they really do not have access to properly represent interests of their community, including religious freedoms and identity within the wider environment. Yes, there are, of course, political barriers related to individual doctrines. Yes, some of them are, let me use this very UN jargon, not to make controversies. Some of them are very conservative, some are less conservative, some accept discussion on specific topics, like, for example, reproductive health and rights, some not, etc., etc. So we have this big package of political reasons, political barriers that need to be taken into consideration when we discuss possible solutions. But we have also a package of practical barriers, which are sometimes even more important because they are those barriers without removing which we are not able to move forward. And these are mainly related to this representativeness, practical representativeness, but also access to evidence and information. And I think that what Marie was very correctly mentioning relating to stigma and discrimination, for example, is an excellent example and very often associated with faith partners of any response, including health response. Yes, we in our field of HIV/AIDS, we know it very well because until today, even if we live with the AIDS epidemic for 30 years, until today we still have some churches and some, maybe not as institutions, but I should narrow it down to some religious leaders or some FBOs who are causing a lot of stigma around HIV status, yes? And we are making a lot of effort to turn, this stigma notion of different religious groups into championing individual or groups or FBOs around the same religion groups to be best respondents to the stigma around HIV or around Ebola or COVID. So this is something that exists and will probably continue existing, needing our close attention. I think that one of the important elements within the discussion about barriers is related to the fact that many religious groups are or owners or managers or supervisors of health facilities. In many countries, and especially in the developing world, we have a serious percentage of national health systems belonging to different churches. And within this setup, very often we see the differences what nationally owned clinic is doing differently to church-owned clinic. And we have plenty of confrontations here, misunderstandings here, and this is related to lack of proper evidence and information. That's why I think one of the solutions that works from our point of view is that all of us, parliamentarians, religious leaders, activists, FBOs, we try to reach out to the proper information that is verified, that is provided by reliable sources, and we should not shy away from this information, even if we not necessarily like the institution, UN or whoever else, yes, European Commission or whatever, because like the access to key information and data is already half of the success for addressing problems of my community. About the roles, I think...
Just giving you the warning. Ding, ding, ding.
Okay. So very quickly, I will not repeat. Marie addressed it very well. The roles of religious leaders, parliamentarians, others, creating enabling environment for sure. This includes eliminating barriers. This includes legal framework where there is a need for advocacy for religious leaders and acting by parliamentarians. What also works very well is interfaith dialogue on key issues, and preferably dialogue that is leading to joint initiatives. Let me then briefly address resources. Of course, it is extremely important to have access to resources, and there is a number of resources here. There are almost in each country we have something called interfaith or interreligion council on health issues, on other issues, on whatever issues. We have to make sure that these councils prioritize health, because this is the formal, nationally recognized access to the debate and discussion. We have plenty of guidance materials within the UN system developed for faith groups and faith activists on different issues. They should have easy access. We have something called Interfaith Health Platform, which is collaborative space for community building, awareness raising, joint advocacy among faith partners engaged in HIV, but it is also documenting the impact and faith models, including under the current challenge of COVID. I will share the link in the chat when I finish. Concluding, I see two steps. Step number one, as recommendations for action. Step number one would be proactively looking for entry points to participate in the debate and the follow-up implementation of health issues by religious groups and leaders. And second, moving from ad hoc, like for example, it was a case with Ebola, yes? The Ebola crisis came, many churches, many local churches in Western Africa stepped in, playing a wonderful role and helping a lot. The Ebola finished, they completely disappeared. They are there, but they are not participating in the continued dialogue with local country authorities or wider system for the health response, which is a pity because it is a lost opportunity. So the second step would be moving from ad hoc approach towards a sustainable role of faith partners. By this, I mean faith communities, religious leaders, FBOs, in any debate related to health, because only by participation we can ensure that interests of our members will be met. Sorry for speaking too much.
No, thank you so much, Jacek. That's so much wisdom there, and really encouraging for exactly what we're trying to do today. Just create that space and that debate, and we might not all be on the same page, and that's okay, and we just need to meet each other where we're at the moment. But so much wisdom and expertise there. Thank you so much. That's given us a lot to work with. And immediately, Bicbic, I'm afraid you don't have tons of time, but I would love to hand over to you now. So Bicbic is the Executive Director for Catholics for Reproductive Health, and is sitting at the intersections of that really, don't know what the right word is, it is controversial, but of that really sensitive but deeply, deeply important area where we look at religion, health and gender. So I'd love to hand over to Bicbic now, who can share more about her work on that.
Thank you, Catherine. Kat, I would be going on through my script because I would like to maximize my time and I would like to share so much. And I would like to thank Marie and Jacek for discussing the things, providing the background where we are working. I would be sharing more on the personal side and what our organization is doing. We're doing a lot of advocacy as well and some discussion and conversation, but allow me to share from a personal point of view. Like, I would like to inform I was born and raised as a Catholic, and I always believe everyone should live their lives meaningfully and to the fullest as a way of showing God's grace. And we have this saying locally in the vernacular, nasa Diyos ang awa, nasa tao ang gawa, translated in terms of it is God's mercy, but it's up to people to do the work. With God's guidance, inspiration, and blessing, we should explore how to improve our life situation. Saint Irenaeus once said, Gloria Dei vivens homo, or the glory of God is a human being fully alive. Being fully alive does not mean just breathing, but having quality, fulfilling, and dignified living where we have the means not just to survive, but also to develop ourselves befitting of God's likeness and image. The Imago Dei is a powerful message for us in the Catholics for Reproductive Health as we navigate the challenges of everyday realities as well as addressing the difficult conversations that touch one's core beliefs and values in life. We at the Catholic for Reproductive Health, our organization is a national group in the Philippines and a fellowship of the individual Catholics who believe that reproductive health is a right. It has been mentioned that sexual and reproductive health and rights are one of the contentious issues with regards to freedom of religion and belief. But our experience, we were able to bring some results. We were able to encourage our members, individual Catholics, that there is no dissonance in being Catholic and believing in the advocacy and goals of reproductive health and rights. Our members remain loyal to the church but continue providing reproductive health education and services to those who truly need them. We also believe in the primacy of conscience and encourage fellow Catholics to educate themselves and develop mature conscience in discerning their situation and actions guided by our Catholic teachings of social justice, love, and compassion. And we do this through education, capacity building, advocacy campaigns, community outreach and service, and interfaith initiatives. Since many of the resistance to family planning and sexual and reproductive health and right is brought about by lack of information, misconceptions, many of which are religious in nature, we reach out to other faith-based organizations. We found out that faith-based organizations are just as eager to participate and engage when conversations on family planning and sexual and reproductive health and rights are linked with other social realities like poverty, gender inequality, public health concerns such as maternal mortality, teenage pregnancies, HIV and AIDS, and even the harm of unsafe abortions. Interfaith partnerships also provide alternative voice and important counterweight to conservative religious views on family planning and sexual and reproductive health and rights. We have an interfaith for dignity and equality, advancement and solidarity, or our ideas. This is our interfaith platform. When opportunity arises, we partner with different organizations, international, national, and local, government units, academe, private, and grassroots. We find this very effective not only in terms of resource sharing, but also expanding our reach and influence in the process. And our partners are then transformed from being our allies into our champions and advocates themselves. And we have found that when we successfully lobbied and passed a national policy on reproductive health and responsible parenthood. We are building a broader and more inclusive faith, interreligious, interspirituality platform for people of faith to talk about sexual and reproductive health and rights. Now we are seeing churches starting their conversations in their parishes. They have also included women's concerns and family well-being into their programs, and some have piggybacked reproductive health in their local campaigns and ecumenical activities. In our organization, C4RAs, we emphasize the importance of conversations and dialogues, of listening to one another, of finding common grounds where we could agree and work together, and upholding mutual respect, as we recognize that our divergent views do not diminish our humanity and the sacredness of our respective faiths. In every conversation, we encourage everyone to put ourselves in the shoes of the people whom we profess to help. Oftentimes, we just have to be brave enough to feel how it's like to be poor, marginalized, excluded, and imagine if our choice and agency are continually ignored, if not outrightly controlled or violated. That is why it is important to address the gender dynamics of sexual and reproductive health and rights, analyzing the system of domination, oppression, exclusion, and replace it with a culture of nurture and inclusion, of compassion and love. Specifically, with reproductive choices, we have to ask who decides over what, and who benefits and who bears the burden. These are just some of the recurring talking points that we have whenever we mobilize and gather women of faith. We have the Women Celebration of Life and Faith as a platform to strengthen sisterhood, solidarity, and action. For us, the process of discernment, and we do this not only for our members, but also with our advocates, with our legislators, with the executive leaders, um, community leaders. We encourage them the process of discernment, particularly with regards to sexual and reproductive health and rights concern, and translating them into constructive action requires courage to open our hearts and minds to realities of people we serve, the commitment to help and love unconditionally, and the conviction to uphold human rights and people's dignity without judgment and discrimination. And that is with what we believe is the essence of freedom of religion and belief, and that is the essence of our faith tradition. So that's where we are at now with Catholics for Reproductive Health. Thank you.
Bicbic, thank you so much. I'm so excited that you've been able to share your wisdom and your experience of working so gracefully in on such a contentious issue, and you come with such compassion when you work on these topics. And yeah, really, really glad that we've been able to hear from you, and you've set us up perfectly. Thank you so much. It is now our turn to head into the breakout groups to reflect on our own what we've taken away from today, and to share what's happening around us. Amazing. So thank you so much. Thank you so much for coming back. Sounds like that was really good. Really good conversations. Just immediately wanted to pass on to a couple of people who really pleased are able to join, and then really we'll pass back to Bicbic, Debbie, as you've said, and then open it up a bit more. Just quickly wanted to pass to Dr. Salman Wakar, who I know is working on the intersections of faith and religion and access to health, and particularly looking at Islam and different patterns. Salman, can you share a couple of reflections from everything you've worked on, and then from what you've heard today?
Wow, okay, so summarize the last 2 years in 30 seconds. So I think, one of the things that we have found, particularly, for the context of people who don't know, the Muslim community in Britain, where we are in the UK, is around 3 million people, about 5% of the population, but an incredibly minoritized population. So an intersection of low socioeconomic class, a migrant community, and also a faith minority as well, in the context of significant amounts of Islamophobia, anti-religious sentiment, and general xenophobia in society. So it is no surprise then that the health experiences of the Muslim community are suboptimal, and the outcomes for that community are also suboptimal. And so when it comes to a pandemic, which many have commented is actually a syndemic, with the twin forces of the biology and the sociology combining to give disproportionate, enduring outcomes throughout the entire course of the whole story, has meant that our community has consistently been on the back foot. And that is all the way from being keen to follow government orders around social distancing and sort of the social interventions, all the way to the pharmacological interventions. And one of the things that we found very early on is that the messenger is far more important than the message. And that's where our faith community has been very, very impactful in being able to take the same message, the exact same wording. You don't have to translate a single word, but you just have to put it in the mouth of someone who is trusted and respected by those communities. And I think that's really important. And we've also recognized, especially nowadays with social media and the sort of global village that we live in, what's happening in Africa, in Asia, in Latin America, ends up on our doorstep as well. And we have to come up with global solutions to global problems. And it's very difficult when you're trying to overcome fake news when it's being imported from WhatsApp groups and Telegram and all these spaces overseas. And then the other thing that I just wanted to touch on is around data and monitoring of faith. In our part of the world, talking about faith is very difficult in society, let alone when it comes to health. And we've seen the inability to do that has actually led to the state that we're in. When people haven't been able to talk about their faith and their belief, it's no surprise then that when it comes to vaccination, they're not being asked about what their faith thinks about vaccination. When it comes to faith institutions being involved in the delivery of healthcare, if up until now they have been ignored and not invested in, is it a surprise then that they're not able to quickly respond and react? Although the efforts that they have done have been valiant, how much better could they have been had we had a honest, mature dialogue and investment over the years, where faith communities were very much part of the infrastructure and systems to be able to overcome it. I do have a lot of hope for the future. I think there has been a lot of learning, and I'm hopeful that forums like this and conversations like this will allow us to continue to do the good work that we have done and learn from each other. So thank you for inviting me, and thank you for doing this.
Thank you, Salman. And I think it's a really, really helpful example of what different communities, more marginalized communities in different countries might be facing, and that we need to have this lens to make sure that we are interacting with and asking the questions that are needed and connecting, like you said, with faith leaders. So while it's a UK example, it's also a really international example in that we will find similar patterns in different countries, people experiencing similar things. But thank you so much for bringing that forward and sharing that. It's really, really helpful for us to know. And yeah, be really excited to keep talking with you as well going forward. Bicbic, I'm actually going to come to you next. Love to just hear your immediate thoughts from the breakout room.
Thank you, Kat. Actually, I'm going to just share a little bit what I learned from the group in terms of issues and concerns. In the Asian group, the health issues are the intersectionality of the health issues are emphasized, and based on the questions that were raised, we were only able to get the opportunity to just answer one because of the limitation of time. But nevertheless, the discussion was really rich, and in fact, if I may cite some of the concerns raised, with regards to the freedom of religion and belief and the access to health, we have to take we need to address the issue of economic equity, and we need to empower women as well, because as I mentioned, I think earlier, we cannot have our women and mothers unhealthy, and therefore we have to take care of them. And one way of helping them out is really addressing not only their situation in terms of economic situation. And then it was also discussed the effects of COVID on the minority, wherein in some areas it has been the vaccination or even the lockdown is used to further marginalize minority groups. Some would have more access to vaccine, some do not have access to vaccine. Okay, and then there's also the issue of doing some policy advocacy, not only at the local level, but up to the international arena, so that these policies are would provide that framework of service as well as education. And when we talk about education, we also have to address the cultural institutions, like we need to make people aware about the needs. I'm sorry, I'm just looking at the notes. Yes. Do I get Debbie? I need your help here, perhaps.
Okay, thank you so much, Bicbic, for listening to the group. One of the approaches was actually to ensure that economic engagement, including aid and development aid with countries, ensured that there was a better, stronger national priority for health. And we could see in some countries, the budget priority was for defense instead of health. And in that kind of situation, it is religious minorities who go further down the bottom of the barrel and are exposed to, malnutrition, especially children and so on. So the worst health outcomes inevitably reach minorities. The weaponization of COVID by some repressive governments to punish or exclude religious minorities and perceived dissidents was another issue. And there was also a concern when we talk about the economic aspect that majority group versus minority group dynamics in some countries, or in Malaysia, for example, meant that the majority religious group gave a lot of protection and shielded perpetrators of corruption. And that in itself creates an imbalance in terms of resources available for general public health and social services. I think one of the interesting things that came out also was the concern that lockdowns, especially in densely populated areas, meant a potential of heightened polarization because of people's mental health being affected by extended lockdowns, by economic uncertainty. And when we talk about health, we haven't really addressed mental health in the broader discussion. So I think that's about covered most of the points that were made. Thank you.
Thank you.
Thank you so much, Bicbic.
Thank you, Bicbic. Thank you, Debbie, so much for that. Really glad we've been able to capture that. Want to immediately acknowledge as well, really grateful that Honourable Zawera and Honourable Nyako from Ghana are here. I'm really pleased that they're part of the conversation. We will be staying around for 10-15 minutes extra. I realise some of you might need to go, but I really want to immediately pass over to Dr. Shridhar as well. I'm just pulling up, excuse me, just pulling up, there we go. Dr. Shridhar Venkatapuram, who I know has been working on these issues as well. Sorry for the very brief introduction, but just wondering if you had any immediate short kind of reflections.
Yeah, so there's been some fantastic and incredible things that I've learned and I've heard today. So the one thing that I would like to add to the pot is that faith-based organizations and communities can be great advocates for local and global equity. And what we have seen over the last 2 years is a failure by national political governments to think beyond their own borders and their own political domestic systems. And faith-based organizations have the ability to look across political borders and also the short term of political cycles. And there's two things that happens. One is that providing people with experts or scientific facts is not convincing, and providing people with even ethical arguments is not convincing. But it also seems that perhaps faith-based reasoning could be convincing. So we need all different kinds of arguments that move towards improving health and human well-being, not only domestically, but around the world. And I just encourage everyone to think about how can we use faith and faith-based organizations to move us towards greater equity, not only locally, but globally. Thank you very much for this opportunity.
Thank you so much as well. I'm really blown away by everybody's interventions today and the kind of wisdom. Certainly for me, working in FoRB for 10 years, I haven't heard much of this. So that's really, really exciting. Thank you so much. We'd love to keep working with you as well, Dr. Chua, going forward. Can I ask, is there anybody from the Africa group who is in there who might want to share anything? You can just start speaking, or maybe you could raise your hand and then I can have help to identify you. Just looking for anybody. No pressure. If not, Gifty, I don't know whether you want to say a few sentences from what you've heard. Oh, is Gifty with us? I don't know, Jimmy. All right, no pressure. If was there anything that's merging out of that part of the world? That's all. That would be really good to hear. If not, we can come back to it later.
Hi, Catherine.
Yeah. Hi, Jimmy. Yes, please. Would love to hear from you.
Yeah, we had a moderator, and the conversations were quite well moderated there. And I really, what really caught my attention is how the intersection between the traditional beliefs and systems and faith, and also the beliefs around healthcare, access to healthcare, and how those are also being accommodated by the emerging, single individual-led faith congregations and communities. So I think that also affects very much, especially because most of the adherents of these faith and groupings and belief systems are in the rural areas and are not linked to the formal systems and processes. So the ability to access health, or also the ability of the formal system to tap into the indigenous knowledge about health is also hampered. There's little studies done about that. So that also affects, and of course, where there's minorities, the women are mostly affected in terms of access to quality health. Issues of FGM and sexual-based violence, in whatever form they occur, sometimes are reinforced by some belief practices, which are camouflaged under religion, but they are not under the religion as we know it. So the studies need to be done around the traditional forms of practices, and also how faith leaders as peers within the interreligious or interfaith mechanisms can learn from each other and can sort of check on each other in terms of when it comes to access of health. I also caught the conversation around faith-based on the health facilities and infrastructure, which are quite huge and quite an investment. And sometimes this can also interfere with access to health because maybe somebody believes that if they go to a Catholic hospital, they'll be converted, and the reverse is true. But the conversations are quite rich, and I really think the input from the parliamentarians, politicians, and a cross-section of lecturers and everybody else made it quite rich and diverse. Thank you so much.
Thank you so much, Jimmy. As always, really, really grateful for that insight, and really enjoying hearing kind of the newness and linking different ideas together. So making sure we think beyond, like Dr. Chua, beyond borders and the way that religion plays an impact in our world that does transcend national borders, but also beyond the traditional faith institutions that we think of, Christianity, Islam, Hinduism, and many others, but actually to many parts of the world look at more indigenous belief systems and making sure that the wisdom there, the local wisdom, is integrated, and that we're also engaging with it and interacting and learning. So that's really, really helpful, I think, for working across different parts of Africa in particular, but completely all around the world as well. So much richness for us to learn from. I just wanted to say a couple of small things, and then we will be staying around, like I said, for a few more minutes. So if there's anything else anybody wants to say. But for those of you who do need to go, thank you just so much for joining and being part of the conversation. It's been really, really exciting and wonderful, and quite a lot of newness for those of us, I think, working on freedom of religion or belief, lots of learning that we've had. There is one more event in our series, that's next month. It's on the 24th of February. Again, really exciting conversation. It's all around climate change, around religion, religious institutions, connections, networks that we're talking about, and climate change and our connection with the world. And again, I think we will need to work with faith communities beyond borders. That's a really important perspective there. Registration for this event is now open. I believe that the link will appear in the chat now. Please do join in 5 weeks' time. Please also do not forget the advocacy piece, which is saying that exactly what we're doing today is important, basically. Please, if you are able to, do just sign in your own capacity. You don't have to sign as an organisation, just to say that when we're looking at SDGs, freedom of religion or belief does need to be considered. Everything we've been talking about today. Do write to me if you haven't had a chance to speak. Write to me directly in the chat. And also, lastly, my colleagues will provide a post. They'll post a link to an e-evaluation just for you to give some feedback about what's been good about today, what hasn't been good. There is never enough time. We realise that's one of the biggest challenges. And when we start to open these spaces for conversation, it's very, very hard to stop because there's so much to work on. But that's the joy of it. So we will keep working and do follow up with you.